Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. For decades, rheumatology has operated under a pretty fundamental assumption. Autoimmune disease can be controlled, but not erased. We've become very good at immunosuppression, especially after the advent of biologic and other targeted therapies. With B-cell depletion, cytokine targeting, JAK inhibition, these therapies have really changed the outcomes for millions of patients, but they rarely produce a cure. And then a few years ago, a group in Germany led by Dr. George Schett published something that really stopped a lot of us in our tracks. Patients with severe refractory lupus received CD19 CAR T-cell therapy, technology borrowed from oncology for the treatment of cancer. And many of his patients entered deep, drug-free remission that has now lasted 5 years. These patients didn't just improve, they went into remission without any ongoing immunosuppression. And then the question changed from, can we better suppress your immune system, to can we actually reset your immune system and cure your disease? This idea has enormous implications, not just for lupus, but for inflammatory myopathies, systemic sclerosis, vasculitis, rheumatoid arthritis, and maybe autoimmune diseases more broadly. Dr. Schett has been one of the central figures that's driving this field forward. And today we talk about CAR T cells, Tregs, immune resets, cure, relapse, and what the next decade of rheumatology may look like. Dr. Schett is professor and head of the Department of Medicine at Friedrich Alexander University, Erlangen, Nuremberg in Germany. He leads several large research programs focused on inflammation, metabolism, immune regulation, and many others. And he's received numerous international honors, has authored over 1,000 peer-reviewed publications. Please enjoy this conversation with Dr. George Schett. George, welcome to the show.
Hello, it's a pleasure to join.
You've been studying most of your career about immune dysregulation in rheumatic diseases, and then you started your work on CAR T cells. When did you first think that CAR T cells would actually work in the diseases that we take care of?
Yeah, I started in 2020, actually, during the Corona pandemics. Probably I had a lot of time to think.
As we all did.
That's when I started to think about this crazy concept.
It was incredible. I still remember reading your article on those early lupus cases. I mean, because the remissions were so deep. Did that surprise you? Did the outcomes of those first patients that you treated with CAR T cells surprise you?
I had been really surprised. We didn't know actually what will happen at the end, right? Because when you start that, you just don't know where it goes. But at the very early thinking, we thought that it could lead to cure, right? And that's why we did it, actually. That was the main intention, to do that with all the pitfalls, knowing all the pitfalls, right? With potential toxicities or failure to do that. But I think what was really nice, there has been always a vision behind it, that we have to develop something which may cure a patient, right? And that actually pushed the whole story. To be fair, I think with respect to the patient, we always, next to telling what negative consequences this could have, right, with respect to toxicity and non-response, we also told them that there could be a chance that this leads to a very long absence of disease.
For people that may be unfamiliar with that early work, can you just describe briefly who these lupus patients were and what outcomes you showed after their CAR T cells?
Yeah, sure. I mean, these patients consistently had a very refractory lupus with failure to multiple immunosuppressive drug therapies and a highly active disease with inner organ involvement. So usually nephritis, lung involvement, and heart involvement. So these patients have been really in a life-threatening condition with inadequate control of the disease, usually young, usually female, so classical lupus patients. we had not much to offer them, in fact, right? So we decided for this deep B cell depletion with CAR T cells, and which was a classical autologous CAR T cell therapy where you basically take leukocytes from the patient, manufacture CAR T cells outside the body, and then administer a certain number of CAR T cell to the patient by an infusion.
Right. And these CAR T cells basically are targeting their B cells, right? Either CD19 or CD20 B cells. Is that right?
These CAR T cells are designed to kill B cells, right?
B cells.
And they do that by binding to CD19, which is an antigen exquisitely present on B cells. And by binding to this antigen, the CAR T cell then kills the B cells.
When you tell me that, I'd be like, okay, it's like a stronger version of rituximab, right? Or obinutuzumab. Oh, where do you think that comparison falls short? Because it seems to providing outcomes that are way above and beyond what we see with these biologic medications.
Yeah, well, it's a living drug, right? A cell is not an antibody. It's a living drug. It behaves like an organism, like a killer organism. That's what a CAR is like, and it gets more in the body, right? It's a
Mm.
living drug. It multiplies, and it actually works until there is no target available anymore. And that's fundamentally different from an antibody, which is subject to cleavage and clearance by the body through the FC receptor system. And I think that's a big difference. At the end, it's a very different approach to target a disease when you use a cell therapy.
What do you think is actually happening? Is the result that you're just killing off all the B cells? Like, does the immune then do like a reset? Or like, what happens next?
The big surprise to us was that deep B cell killing, which was somehow expected, right, really leads to this long-term remission and drug-free state in a patient. That we didn't know. And that was also a
Hmm.
surprise to us because we thought maybe the genetic background of the patient makes them prone to autoimmune disease, or also other cells involved in autoimmune disease like T cells would actually reconstitute the pathological B cell system, and eventually the disease will come back, right? And that didn't happen in the vast majority of patients, which was really a surprise. So then this concept came up that maybe we somehow reset the system or the immune system, and there's still an ongoing research how this reset is structured, right? It definitely means that you have a completely revamped B cell system without memory cells anymore, right? There's only a very naive B cell system, which is similar to the B cell system of the child. But there is also other changes in the immune system. For instance, a collapse of the type 1 interferon response in the T cells, which is important in autoimmunity. Toll-like receptor pathways are downregulated, complement pathways are downregulated. So it's a very broad immune homeostasis which you create. And this finding actually led also to, I would say, a better understanding of the role of P cells in this whole
Hmm.
autoimmune process as an orchestrator of different pathways, which are also in the non-B cell lineage.
How do these findings help you better understand how the immune system works and how autoimmune diseases develop?
Yeah, I think we cannot actually say how autoimmune disease develops so easily by these results, but we can probably say that B cells are needed for the development of autoimmune disease. And that's also reflected by the early B cell signal in autoimmune disease pathogenesis already before the onset of clinical disease, which is very consistent in all kind of autoimmune diseases like rheumatoid arthritis, lupus, ANCA-associated vasculitis, type 1 diabetes mellitus. But what is also interesting in the concept of pathophysiology of autoimmune disease is the fact that most of the people always think a linear line, there's an antigen presenting cell, then there's a T cell, a B cell, and then a plasma cell making the autoantibodies. And
Hmm.
that's actually one line. But in fact, that's not what I think is true, because that concept neglects a little bit that B cells are antigen presenting cells. They are telling also T cells what to do. It's more a network than a linear line, right? And I think this data also suggested that it's not only the autoantibody which does the damage to the body, it's probably the B cell itself which is important. And by multiple mechanisms, this B cell orchestrates autoimmune disease. And if you block that, the system crashes completely. And I think that's something we have learned from these studies.
Do you think that these CAR T cell therapies has like erased the autoimmune memory of the body? Like once you take out these autoreactive B cells, is that it for autoimmune disease?
Yeah, it seems so, right? This autoimmune memory seems to be really depleted in the vast majority of patients. And that seems to be important, right, for triggering this sustained remission. Now, one has to still learn a little bit more about autoimmune B cells. What happened to them? Are they just have another gestalt or are they really not anymore existing? That's not fully
Hmm.
clarified and some more work is needed, right, to understand that. But what you really create is a new level of immune homeostasis, which is rather
Hmm.
stable, right? There are certain triggers for autoimmunity, like infections and stress, sometimes pregnancy in lupus, or for instance, sunburn, right, in
Hmm.
lupus, right? So
Mhm.
there are certain triggers and patients seem to be rather resistant to these triggers to get a newly develop autoimmune disease, which is quite remarkable, I would say.
And so those first patients you described had lupus. Talk a little bit about what other diseases you think are particularly suitable for CAR T cell therapy, and then some of the other additional trials that you've led based on your previous work.
Yeah, but in the rheumatology arena, I would say there are a couple of others diseases where there is interest in CAR T-cell therapy. One is definitely systemic sclerosis and another one autoimmune myositis. Both of them have substantial disease burden, potentially being life-threatening, right, due to lung and heart involvement and limited therapeutic options, right? And while some of the patients are doing well with current treatment, and there is also some substantial progress in these two diseases in the last years, there's still an unmet need, I would say, for severe and resistant cases. And there, the initial data, also from several different groups, have now shown that there is a substantial effect on lung and skin disease in systemic sclerosis and on muscle and lung disease in autoimmune, different forms of autoimmune myositis. So there is actually hope that the data in lupus are transferable to these two severe rheumatic diseases. And there's some less data on rheumatoid arthritis and ANCA-associated vasculitis, but also first promising data are there. I think rheumatoid is much more better tackled disease than the others, right, with respect to available therapies. But still, there is a subset of patients with high resistance, and ANCA-associated vasculitis has a good response to rituximab. It's a severe disease, it's rare, severe, and there is still some unmet need to develop better therapies. So in general, there are a couple of other rheumatic diseases which seem to be important for CAR T-cell therapy. And outside the rheumatic spectrum, I would say many data have been done in myasthenia gravis, some data also in multiple sclerosis, and a few data also in, for instance, hematologic autoimmune diseases like autoimmune hemolytic anemia and immune thrombocytopenia.
You're not only sort of investigating these, but you're treating patients. You led this trial that also included patients with systemic sclerosis and myositis. Talk a little bit about those outcomes. Were they as good as the previous outcomes with the lupus patients?
The second disease we treated has been autoimmune myositis because we felt there is it's a quite aggressive and progressive disease, right? Especially those with interstitial lung disease. So we could have an outcome parameter which you can easily see in lung function and overall improvement in the physical performance, right? Which was quite tempting to do severe myositis patients at the very beginning. And we had this patient improved dramatically with respect to muscle function and lung
Hmm.
function. And I think that led actually to further studies in the field of autoimmune myositis, where actually you can have very good measures of improvement. And then we actually also went to systemic sclerosis because there is a substantial unmet need. And it was really eye-opening that skin fibrosis improved and also lung fibrosis improved. And
Wow.
the recent developments also with more composite outcomes in systemic sclerosis initiated by Dinesh Khanna, like the CRIS score, that helped us also to test these outcomes in after CAR T-cell treatment. And the first results are very, very positive, right? That there's a comprehensive improvement of patient state, skin and lung involvement in systemic sclerosis.
I mean, it's incredible that we're seeing reversal of fibrosis and many of these patients, as you've shown, have gone into sort of drug-free remissions, at least for now. You've mentioned that you're using CAR T cells for patients with pretty refractory disease where we don't have very many other good options for patients. Do you think that at some point we will be treating, patients with rheumatic disease a lot earlier after diagnosis of somebody with lupus or myositis or rheumatoid arthritis, that we could, in theory, potentially cure the disease and have them no longer need to see us in clinic?
Yeah, I mean, you're absolutely right. The refractory disease has been an open door, right, to introduce CAR T cell therapy in autoimmune diseases. So that has been the way actually to move into that, right? Slowly. Now, you're absolutely correct that we suffer from, or patients suffer, and also the physicians suffer from the fact that they cannot actually revert the disease completely if there is some disease history, meaning there is, for instance, filter function damage in the kidney or scarring of the lung in the context of fibrosis, and also vascular loss, right? In, for instance, systemic sclerosis or myopathy in myositis. So there are a lot of damage issues in long-standing autoimmune disease. So that the idea to go earlier in a risk population is very attractive. I think we have quite good clinical tools to define high-risk patient with high risk to have organ failure. And this is, I think, a very interesting population to go early and don't risk actually to accrue damage and make the situation irreversible.
Amazing. It's been amazing work to sort of see where this has been and where the field is evolving. A couple of weekends ago, I heard about a sort of a novel way of sort of using a similar therapy, which is regulatory T cell therapy. So right now, the work that you've shown, you've sort of try to delete the B cells, the pathogenic immunity. But this other approach, about regulatory T cells, they sort of aim to increase the existing Tregs in autoimmune disease, and maybe through that way, potentially also help to get patients into remission. I wonder your thoughts about Tregs and sort of CAR T, and could that be a potential option for treating patients with autoimmune disease?
Yeah, thank you for mentioning this. This, I think, a very interesting approach. The story is basically that with a regulatory T cells, you would create a local regulatory environment, right, in the site of inflammation and inflammatory-based tissue damage. And based on this immunoregulation, you would turn a sustained immunoregulation, you would turn down the process, which is, I think, a very attractive concept. Now, initially that was followed very much by polyclonal Treg infusions, right? And that showed some effects, for instance, in ulcerative colitis, but you have to repeat it, right? So there is a sustained effect of a polyclonal regulatory T cell therapy. So there needs to be actually technical advances to maintain a regulatory T cell function in a certain area of the body where there's inflammatory process. And there also CAR technology is super interesting, right? And therefore this kind of CAR Tregs exist, where basically the CAR is actually first targeting a certain cell population involved in the disease, like, for instance, B cells or particular antigens involved in the disease. And upon recognition of that target, then the regulatory T cell function is initiated in this CAR cell. And this regulatory function would actually provide a so-called immunosuppressive environment, which turns down the inflammatory process. So this is a very interesting concept. And I think there are at the moment already initial studies started in rheumatology, for instance, in rheumatoid arthritis or in systemic sclerosis. And I hope that we will hear more in the future.
This has been an amazing time for CAR T cells. I know that at my hospital, both in adult rheumatology, pediatric rheumatology, everybody's talking about CAR T cells and doing CAR T cells trials. A lot of companies are out there, sort of pursuing these therapies. Do you think that, we're sort of overestimating the potential for CAR T cells now? Are we overlooking certain things that we should recognize where, the current CAR T cell therapies may not give us the outcomes we're expecting?
There are several issues which are not solved, I would say. And one is the fact that the process of the classical autologous CAR T cell production is still a rather complex process, right? It's feasible to do it, but it's complex. So it's not scalable like you give an aspirin to a patient, right? So that's clear. So that's therapy still reserved for the severe patients. And the scalability of cars is an issue in the future. There are some ideas how to overcome that, for instance, with faster production, but also with other technologies like allogenic cars or in vivo cars, where there is a lot of research ongoing at the moment. The other challenge and frontier is, I would say, is what happens with patients not having durable remission, right? With relapses, right? And why are these relapses happening? What is going on in the immune system of these patients that they can overcome this attack by CAR T cells and reconstitute the disease? I think this we have to learn, right? And with relapses happening, basically nothing is 100% in medicine. We will also learn how to better tackle these patients. So that's a process I think we are currently seeing. And I think challenges are with any kind of therapy. We have to learn how to deal with them, also with toxicities, right? An example is cytokine release syndrome, how you prevent cytokine release syndrome, how you treat cytokine release syndrome when it's occurring. All these points are pretty important, right, for the future years.
From the patients you've treated, around what percentage have relapsed after receiving CAR T cells?
About 10%, right, have a relapse, which is, in my eyes, very low, right, because we would not have expected to have drug-free remission, any of them. The fact that we have about 10% relapse is rather low, but still, this is an open issue, and one has to see how you treat these patients. For instance, can you treat them with conventional drug therapy? Do you regain susceptibility to conventional drug therapy, which is a very interesting question. And the other one is, can you repeat it? Can you repeat a CAR T cell infusion in such a population?
Do you think it's feasible that one day we'll have like off the shelf CAR T cells that you can just give patients? Or do you really need to do the whole harvesting and do sort of patient specific CAR T cells to manage autoimmune disease?
Yeah, I would say it's feasible, right? I mean, the first data on allogenic CAR T cells in the field of autoimmunity have been published with stimulating results. One has to see how a long-term efficacy looks like. But I think when you ask me if it's feasible to that we will face off-the-shelf cars, I would say yes, it's feasible.
Amazing. And then I guess the other part, you're thinking that maybe the cell, it will be easier to deliver the cells to patients. And will there be ways of reducing those risks of like cytokine release syndrome? Do all patients need chemotherapy? How much, do we need to immunosuppress them before delivering the CAR T cells?
That's also an open question because the current protocols have been adopted from oncology and are not developed in patients with autoimmune diseases, right? They are basically made for getting maximum success for CAR T cell therapy. And it's an open question whether you can reduce the lymphodepletion, which is usually done with cyclophosphamide and fludarabine. But there are multiple efforts, right? Experiments or studies are testing that now, right? And to go for a reduced lymphodepletion or even completely without lymphodepletion. We will see how these data look like, but I think there is a very active field to test that at the moment. I guess we will have these answers in the next year if a reduced lymphodepletion protocol is feasible, or if actually you sometimes can do it even without a lymphodepletion. This is really important for patients because one wants to have a minimal exposure to lymphodepletion, of course.
Unbelievable. How do you think we're going to be treating patients, 5 or 10 years down the road, given the huge advances in CAR T cell therapy for many of these patients?
Yeah, I think the field changes now a little bit, right? Because we have, in the last 10 years, we have actually learned how to suppress a disease in a specific way, in a much better way, right? Many of the monoclonal antibodies which have been developed in the treatment of autoimmune disease have a quite good safety, right? And they have good efficacy to control the disease, but they can't cure the disease, right? And the next frontier is really, can you have curative intervention or resetting intervention, which means that the intervention lasts for a certain time, but then actually the disease is gone and you can stop everything. And I think that's the real new frontier. And my vision in 10 years is that more patients are exposed to such therapies, that they actually get a curative therapy for autoimmune disease, like for cancer. And then the patient is clear to be cured after a certain follow-up time, and no therapy is anymore necessary. I think that's where we have to go also for sake of our patients.
Amazing. That means we're not going to have a job to do in the future because we're going to be curing our patients. That would be amazing. That would be
Yeah, always new
amazing.
patients, right?
So many patients. I remember, like, even when I started fellowship, asking, is there a cure? And, I always told them, no, there's no cure yet, but maybe in the future. And it's so awesome to read about these studies that patients have been cured. So, how long has the first patients that you've treated with CAR T cells, how long has it been? How long have they been in remission?
Now it's over 5 years, right? For us, it has always been a magic thing, the 5 years, right? We're thinking a little bit, we're looking always a little bit at our cancer doctor colleagues, and they actually, this 5 years, magic 5 years. And we have now passed 5 years with the first patient, and many will follow, right? Having now more than 4 years, no disease. So I think it's fair to wait for some time. One has to be always cautious, right? Not to be over optimistic, because things can come back after a certain time. But I think we are quite optimistic after 5 years, I would say.
Yeah. Are there specific concerns that you're looking for in sort of the long term, either risks or efficacy of CAR T cells?
Well, I think we follow these patients, of course, right?
Hmm.
I would think I'm really not that concerned on the long term issues, because why? Because the cars are not anymore present, right? The cars, they disappear already, let's say 6 weeks, 3 months after the therapy, and
Okay.
the B cells come back, right? So it's not, we are not that concerned on long term CAR toxicity so much in the autoimmune disease field. We are rather optimistic on infections, right? Because you don't need treatment anymore and you have a reconstituted B cell system. We have to learn about vaccination efficacy
Mm.
in a post CAR time, which is
Are
not.
they getting vaccinated with all the
Yeah, they,
childhood
they get,
vaccines?
right? They get, and the
Mm.
initial vaccination data look good, right? That they get humoral responses, meaning anti-vaccine antibodies. So that's rather positive. But one has to actually study that, right?
Mhm.
Long-term safety and long-term efficacy is something where there's crucial data lacking at the moment, and we have to, but they will come, right? Because with each patient treated, we will follow them up, basically all of them, and you will get some data on these answers on these questions.
Amazing. Georgia, it's been amazing to read about all the studies you've published, those early lupus patients, the Castle study, and everything else you've done. It's been amazing just to be part of rheumatology and seeing all these trials happening, at my own hospital. Thank you so much for all your contributions in sort of pushing CAR T cell therapy in patients with autoimmune and rheumatic diseases. Maybe we'll have you back on the podcast to talk about some of those long-term outcomes, to answer some of the questions that you brought up as well.
Thank you, Jon. It has been a pleasure to talk to you. I hope you enjoyed as well. Really interesting
This is
conversation.
fun.
Thank you very much for
Of
invitation.
course. One thing that stood out to me in this conversation is how quickly our goals in rheumatology may be changing. Not that long ago, remission felt like an impossible goal, especially in diseases like lupus, myositis, or systemic sclerosis. And now we're really having serious discussions about drug-free remission, an immune reset, and potentially curative therapies. Of course, there's still a lot of unanswered questions, including the durability of response, potential relapses, the toxicity of these therapies, access, cost, and scalability. But it certainly feels like cellular therapy is no longer theoretical, but it's actually here. Certainly, the next few years may reshape how we think about autoimmune diseases and what we believe is actually possible for our patients. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, let's continue to aim to cure our patients. And of course, stay healthy.